All right, so the rationale behind the trial was to look at the standard of care for prostate cancer. So when we set it up, the mainstay of treatment was long-term hormone therapy, androgen ablation therapy, and that's been the case since the 1940s. The only change really in the upfront care has been the addition of radiotherapy, for high-risk, non-metastatic disease based on trials carried out a couple of years ago. Around 10 years ago, docetaxel was licensed for prostate cancer on the basis of improved survival in metastatic relapsed disease, and just prior to that, zoledronic acid was licensed on the basis that it reduced symptomatic skeletal events in bony metastatic prostate cancer. There was also quite a strong trend towards zoledronic acid improving overall survival, but the licensing trials were actually underpowered. There was a previous trial with clodronate at diagnosis in metastatic prostate cancer run by the MRC, which did show a survival advantage. So at the time we set the study up, it seemed plausible that both docetaxel and zoledronic acid might improve survival more if we used them at the time of diagnosis rather than at relapse. So the data we presented today, and we previously presented it at ASCO, it was an updated analysis today, is looking at 4 of the original arms. So the STAMPEDE trial has actually currently 8 comparisons in it. We just presented data on 4 of those, which was docetaxel on its own, docetaxel plus zoledronic acid, and zoledronic acid on its own, all added to ADT. And we had a population of patients, around 3,000 patients in these comparisons, 40% of them non-metastatic, 60% of them metastatic. In terms of what we found, basically for docetaxel, across the whole trial population, we had around about a 25% improvement in overall survival. If we break that down, and we presented data on that today by M1 at presentation and M0 at presentation, what we see is that for M1 patients, that improvement is robust. For M0 patients, although the trend for prostate cancer specific survival is in the same direction, we actually have very few prostate cancer deaths in the M0 population. They've done actually much better than we expected when we set the trial up. For zoledronic acid, on the other hand, we saw at best a weak effect on survival with zoledronic acid. It's a trend, but no more. It's not statistically significant. And for the combination of docetaxel and zoledronic acid for survival, essentially the data looks like the docetaxel data. In fact, if anything, the combination arm is a bit worse, not a bit better. The other thing we presented today, which we hadn't presented at ASCO, was the symptomatic skeletal event data, or some of it anyway. So we looked at data on time to first SSE for zoledronic acid, docetaxel and the combination. Now the thing that was very surprising to us was that we'd expected zoledronic acid to have a big impact on SSEs because that's what it does in metastatic relapsed disease. But actually we only detected a very small effect on SSEs with zoledronic acid, and even when we looked at the subset of patients with bone metastasis at presentation, we didn't see any effect at all really to speak of on time to first SSE. In contrast, and actually rather surprisingly, when we looked at SSEs in the docetaxel arm, we found there was a 40% reduction in SSEs with docetaxel. So a bigger effect than the effect on overall survival on SSEs. Which we might have expected to see, because obviously we know docetaxel is affecting the disease, but this was obviously important data. So in conclusion, even for the bony metastatic patients, there was no benefit from zoledronic acid, even on bony endpoints. Whereas for docetaxel, not only was there an effect on survival, but there was also an effect on bony endpoints that was bigger than the effect that the zoledronic acid had. So in terms of heterogeneity, we had a number of pre-planned analyses looking at known prognostic factors like metastatic status, nodal status, performance status, age, and obviously by treatment arm. We didn't see any evidence of heterogeneity of effect. It's very apparent if you look at the failure-free survival data. I mean, I didn't show this data today, but very consistently for all the subgroups there's a big improvement in failure-free survival. That includes the M0 subgroup. If we look at overall survival, again there's no evidence of heterogeneity, but for this, when we look at survival in the M0 patients, there's just too few deaths really to say much about it. So moving on to the SSE data, the question is, why did docetaxel affect the number of SSEs to the extent that it did? And I think this is actually an effect that we've seen in other trials as well. So this was seen in the abiraterone, the enzalutamide and the radium-223 trials as well, which is that if you have an agent that improves overall survival, it's presumably in some way reducing the amount of disease or slowing it down. So I guess you're reducing the amount of damage done along the way at the same time, and hence SSEs go down. So I think the most important message is the best way to prevent SSEs is to treat the disease, not to give an ancillary therapy. So looking at the combination of docetaxel and zoledronic acid compared to docetaxel alone, there wasn't really anything that was better with the combination. So obviously there's more treatment. Actually we got less compliance with treatment on the combination arm than on each of the monotherapy arms. And there was really no extra benefit on any outcome. So the survival outcomes were slightly worse, the bone outcomes were the same, and so there was nothing to recommend giving docetaxel and zoledronic acid compared to docetaxel alone. So the main limitation of the study, we made the assumption that the effect on the disease would be the same whether you were non-metastatic or metastatic, and that the underlying biology would be the same. Now the effect on failure-free survival seems to validate that assumption, because we saw the same effect on failure-free survival. What we hadn't anticipated when we set the trial up was that the survival for the M0 patients would improve as much as it did. And the reason we think it improved is the use of radiotherapy. So 2005, the radiotherapy in M0 trials had not reported, so we had relatively low rates of use at the start for radiotherapy. Now those went up as the trial went on, and it was mandatory from 2011. Now we've done an analysis of patients with and without radiotherapy. It's just been accepted for publication, just looking at the control arm patients, and essentially radiotherapy halves your risk of a failure-free survival event. So essentially by permitting radiotherapy in the trial, which was the right thing to do because it's the standard of care, we diluted our power in the M0 patients. Now we did look at should we increase the recruitment to the M0 cohort, but to be honest, we'd have had to have recruited so many extra patients that in the end we decided that we wouldn't do it, and that we would rely on the fact that other people were doing M0 trials as well, and that we hoped that the meta-analysis would answer the question. And so the second thing that was after my presentation today was from the meta-analysis group, which I'm part of, and at the moment we still don't have quite enough events even in the pooled analyses in the M0 setting, but it looks likely that we will have enough events with another couple of years of follow-up. So I think we may well be able to answer the M0 via the meta-analysis route, and it looks likely that in the M0 patients you do reduce your risk of prostate cancer specific death, but that is diluted of course by deaths from other causes. So ultimately whether you'll use docetaxel in the M0 setting, I think will come down to how likely the clinician thinks the patient is to die of prostate cancer. So if you've got somebody with bad prostate cancer but who's relatively old and with comorbidities, you're probably not going to offer them docetaxel, because there are risks obviously, and the risks go up with age and comorbidity. If you've got somebody who's young and fit with bad prostate cancer, even non-metastatic, I think you probably would offer them docetaxel. But that's the main limitation of the trial, is we're underpowered in that subgroup, particularly because of the radiotherapy effect.